quirúrgica. La verdad es que si ustedes, bueno, yo sí me metí al PubMed y puse el nombre del doctor Katz y tiene muchísimos, tiene cientos de artículos publicados, es una de las personas, pues creo que más productivas en el campo que nos va a hablar. La verdad es que va a ser un honor y un placer escucharlo en probablemente una de las charlas pues más complejas, ¿no? Que realmente nosotros no operamos, pero sí somos los que podemos enviar y qué esperamos de estas cirugías en nuestros pacientes reumáticos. Doctor Katz, de verdad es un placer estar con usted, le agradezco mucho nuevamente en nombre del colegio y bueno, bienvenido a México.
Muchas gracias. Hay que recordarlo para mi madre. No se preocupan, voy a dar la lectura en inglés. Pero empiezo con unas palabras para agradecerme a Rolando y Alejandro y todos en el colegio y todos ustedes en la comunidad por invitarme aquí para pasar unos días con ustedes. Es un regalo muy bonito pasar este tiempo discutiendo reumatología y ortopédica y creando amistad y voy a recordarlo para siempre. So, muchísimas gracias. Pero ahora en inglés. I'm going to talk about surgery for osteoarthritis, which is a large topic, and so I'll talk primarily about hip and knee osteoarthritis. We're now required to tell you where we get our money, so here's where I get my money, mostly from grants from the National Institutes of Health and from the Brigham and Women's where I work and from a couple of small foundations, and I'm not receiving any industry support. Is my voice projecting okay in the back? Is it okay? Please let me know if I speak too quickly. So the options for people who have osteoarthritis of the hip and knee primarily consist of arthroscopic debridement and lavage, and as we'll discuss, this is used less and less. Osteotomy, which is not used very often and probably should be used more, and we'll chat about that. Total joint replacement, and there are many different types of joint replacement, and we'll discuss some of these as I go further. Minimally invasive, unicondylar, these are all things that you've heard a lot about, and we'll talk about them in some detail. Let's start by talking about arthroscopy of the knee. Arthroscopy was very tempting, very seductive for orthopedic surgeons in the 1980s as the arthroscope was introduced, because they could look inside the knee and see all sorts of debris and propose that washing it all out would make the knee better. And indeed, many, many patients underwent arthroscopic surgery to debride loose bodies and fragments of cartilage to wash out the fluid. Fortunately, this was subject to a couple of very rigorous studies. The first by Mosley and colleagues done at the Houston VA, which was a very rigorous study that used a sham control. So patients either received surgery with lavage, or they received a sham surgery where they actually had a incision made in their knee, but no actual arthroscopic surgery. They spent the night in the hospital, and the patients had no idea whether they received the active surgery or the sham. And this is what they found. There were 180 patients. They were randomized to 3 groups of lavage, debridement, or sham control. And as you can see from this slide, it's not important to distinguish which is which because they all essentially did the same. So in the first couple of weeks following surgery, patients improved no matter what they got. They stayed the same over the next 2 years with no differences between groups. Sandy Kirkley was a surgeon in Ontario who died, unfortunately, in her early 40s following a plane crash about a decade ago. And her colleagues finished the work that she started and published it in the New England Journal in 2008. She did a very nice randomized controlled trial of patients with advanced osteoarthritis that did not have a sham control, so patients were randomized either to receive arthroscopic surgery or to have a physical therapy control regimen. And the results were identical to those of Moseley. Patients improved in the first month or two and then had no difference after that, and there were no differences at all between the two groups. So by the time 2008 had sort of come and gone, it was clear to people who were reading the literature that there really is no role for arthroscopic surgery to treat osteoarthritis per se. Interestingly, though, most arthroscopic surgery of the knee that's done in patients with osteoarthritis is done for a concomitant meniscal tear and not simply for osteoarthritis. And the question of whether arthroscopy works for meniscal tear is one that we still don't really know the answer to, but there's a couple of studies that are underway. One that has been complete, and which is, I think, a very good study, was done by Sylvia Herlin and colleagues. Dr. Herlin is a Swedish physiotherapist who published this study in 2007, and then her 5-year follow-up just this spring in 2012. It's a small study. There were just 90 patients. They all had osteoarthritis. They all had symptomatic meniscal tear, and they were randomized to either get arthroscopic partial meniscectomy, which I'm abbreviating APM, or a rigorous physical therapy regimen. And as you can see from this slide, there's the surgical group is the red group. There was a difference at baseline. It's a small study, and this sort of thing can happen. There was a difference at baseline with the surgical group starting a little bit worse. This is a function scale. A higher score is better. After the first 3 months, or 6 weeks, I guess, all patients improved dramatically, and after that, there was very little difference going out 5 full years. Very similar, really, to what was found in the studies of Moseley and the studies of Kirkley, the arthroscopy studies for osteoarthritis. So this is the best evidence that we have today, and it suggests that while meniscal surgery may be very helpful in a 29-year-old who gets hurt playing soccer, for the middle-aged person with a meniscal tear in the setting of osteoarthritis, doing meniscal surgery, arthroscopic meniscal surgery, may be no better than physical therapy alone. I'm the principal investigator of a large trial that we've been doing in the United States in 7 different centers. We just finished enrollment a year ago and are going to be presenting our data for the first time at the ACR meeting in November. And basically, our results are very similar to the results of Herlin and colleagues, which you see here. We only go about 6 months out, but our conservative group and our physical therapy group and our surgical group have very similar outcomes after 6 months. Although the non-operative group, many of them do elect to have surgery, about a third of them do. So I think what we can tell patients today is that arthroscopic surgery for meniscal therapy is probably no better in the long run than physical therapy alone, that many patients who have physical therapy for meniscal tear will eventually settle down and get better, and that those who do not can elect surgery down the road, and they appear to do as well as if they had elected surgery right at the start. But 2/3 of patients end up in the same place without surgery. Osteotomy is a procedure that is being done less and less, and it's a challenging procedure for surgeons. It's a challenging procedure for patients. There have been no trials of osteotomy versus non-operative therapy, and it would be useful if there were. There have been trials of different types of osteotomy and of osteotomy versus different types of surgery. And these trials show that the osteotomy arms generally do very well. But I think what we'd really like to know is whether osteotomy is any better than non-operative therapy, and whether it's as good as total joint replacement. And we don't really know that. With alignment emerging as a crucial risk factor for osteoarthritis, research in osteoarthritis has begun to make it very clear that abnormal alignment, severe valgus or varus alignment, is one of the most potent risk factors for progression. I think we'll see more osteotomy, and also with procedures such as autologous cartilage implantation, which we're starting to do more of in the States, and I don't know if you're doing very much here. We only do it in a few centers. But that's a procedure where many of our surgeons will not do the procedure until they've done an osteotomy in order to neutralize alignment, so as not to put all of this load on the repaired compartment and have it break down again. See, here's what the frequency of osteotomy looks like in the States, starting with only about 5,000 procedures in a country of 300 million back in '93, and now it's actually down below 3,000, so we're doing fewer and fewer of them. We do about 200 total knee replacements for every osteotomy. I'm going to talk now, and for the rest of the talk, about hip replacement and knee replacement. And there's many topics I left out, including arthroscopy of the hip for femoroacetabular impingement, which is a really interesting emerging area, unclear whether surgery is indicated and when, and also all of the surgeries that are done on the shoulder and the upper extremity for osteoarthritis. So with apologies, I'm leaving things out, but we only have so long, and there's a lot to say about the hip and the knee. So we'll move on to arthroplasty now. And I'll start with just some descriptive data, and I present these because I'm asked by patients all the time, and by their family members, and by colleagues of mine, so what happens after a knee replacement, and what happens after a hip replacement? And these are some of the data that I usually share. Patients want to know if they're going to survive hip replacement and knee replacement, and I think it's important to point out that although the procedure is getting safer and safer, mortality is still on the order of 0.5% to 1%, and it varies according to comorbidities, but that's the overall mortality. That pulmonary embolus is still a dangerous problem that can occur with these procedures, and it happens about 1% of the time. That infection is more common following knee replacement than it is following hip replacement, and it happens well under 1% of the time. Within the first year of surgery, about 1 in every 200 or so hip replacements has developed a deep infection, and about 1 in every 500 knee replacements. And the other point that I think it's important to let patients know is that revision surgeries, whether they're revision hips or revision knees, have higher rates of all of these complications than the primary surgeries. Once patients make it through that period, how do they do? And there's a lot of data now about the outcome of total knee replacement and total hip replacement. And just to summarize the knee replacement data, about 75 to 85% of patients report improved pain and functional status and satisfaction with surgery. About 10% will report that they're unable to straighten their leg entirely, that they can't fully extend, and about 10% will report that they cannot flex 90 degrees, which has functional implications for doing stairs and getting out of chairs. It's interesting then that although we think of it as a marvelous operation, as patients have been studied more carefully, we see that about 20% of patients do have residual pain and disability. And that problem, a suboptimal TKR, because in the United States we're now doing over 500 million of these procedures, 500,000, excuse me, that problem affects 100,000 people annually, which is more than the incidence of rheumatoid arthritis. So the number of people having knee replacements that don't satisfactorily take care of their pain now exceeds the number of people developing new rheumatoid arthritis every year in the United States. This is a kind of a complicated graph, but what it basically shows are some knee replacement studies on the top. Those are these studies, are the knee studies, and hip replacement studies on the bottom. And the authors have reviewed studies and divided the outcomes into the percent who had unfavorable outcomes, which is the left, satisfactory, and then favorable outcomes, which is on the right. And if we look at the unfavorable outcomes, you can see what I just said a moment ago. The studies differ one from another, but on average across these studies, about 15 to 20 to even 25% of patients complain of residual pain and an unfavorable outcome following knee replacement. Hip replacement, which are the lower panel, is more like 10%. And I think that's consistent with kind of what we see clinically, that patients are generally delighted with their hip replacement, and there is a small but concerning number of patients who are not that happy with their knee replacements. Going out longer term, the issues become revisions, and these are generally done for osteolysis or infection or fracture, and in the hips for repeated dislocations. And another rule of thumb to just help understand is that the risk of revision is about 0.5% per year. 1 in 200 knee replacement patients has a revision every year, and about 1% of hip replacement patients has a revision each year. So the 20-year revision rates are on the order of 10% for knee replacement and 20% for hip replacement. It's important to remember that not all implants that fail are revised. Some patients are too sick to undergo revision surgery. Some patients simply don't want to and would just as soon limit their activities and live with pain. So these are low estimates, in a sense, conservative estimates of the proportion of failures. The failures do differ by sex and by age. So here's some data that we're just about to publish, I think next month, in the Journal of Bone and Joint Surgery, showing a 12-year experience of revisions of total hip replacements. And on average, after 12 years, about 10% of people are revised. So what we're showing here is the proportion who continue to have their implant in place of those who are still alive. And the top line here are the older women, and then the older men, and then the younger women, and then the younger men. So the younger men have the highest revision rates, the lowest survival rates, and the older women the lowest. And that may reflect the greater loading that occurs. The men are on average heavier, and the men are on average more active than the women in this study. I'm going to show the same data now from a somewhat different perspective. These are data that are all in Medicare recipients in the US, which means they're over 65. And I'll start by looking at the bottom panel, and these are patients over 75, all of whom had a hip replacement in the late 1990s, and we followed them till about 2008. We followed them for 13 or 14 years. And what we show here is that, first of all, 58% of those patients by 2008 had died. Another 6%, 5.7%, had been revised, and about 35% remained alive and at risk of revision. For the patients in the 65 to 75-year-old age group, a smaller number naturally had died, 30%. A somewhat larger number, but still only about 9% had been revised, and the majority were still alive and at risk for revision. And I think the message here is that when patients, especially older patients in this age group and their families, talk about the risk of revision, it's really important to understand that the risk of dying over the next decade exceeds the risk of revision by tenfold. So we have about 60% of people dying and 6% of people undergoing revision surgery. So revision is not a primary concern when hip replacement is done in older patients greater than 75. For this age group, where 9% are revised, it's a more important concern because there's still a lot that remain to be revised. And where it becomes a much more important concern is the growing number of patients who are presenting for hip or knee replacement in their late 40s or in their 50s who have, for example, post-traumatic osteoarthritis. And those are the people in whom revision is really an issue. I think the implication here for research and for industry development of implants is that there is no reason at all for us to be developing new implants to increase the longevity of the prosthesis and use them in older patients for whom the existing implants are safe, tried, true, and provide sufficient longevity. So I'm going to talk about a few emerging issues in joint replacement, and the first one is a surge in the use of joint replacement, especially knee replacement. Here are data from the United States starting in 1993 and going up to 2010. And you can see that in 1993 we were doing about 150,000 hips and 200,000 knees. The hips have doubled and the knees have increased threefold from 200,000 to over 600,000. They've increased very rapidly. Some people have done projections, and here's an example of some projections that were done out to the year 2030, where they have, this is Kurz and colleagues, projected that in the United States, we may be doing as many as 3 million knee replacements by the year 2030. It's unclear whether these projections are correct or not, but even if they overestimate by twofold, it's an awful lot of knee replacements, which raises a lot of issues. The first issue is, why is this happening? Why do we have a greater number of knee replacements? One possibility certainly is that there is an increasing incidence and prevalence of osteoarthritis, and that primarily due to increases in the three major risk factors. One is obesity, another is the aging of the population, and the third is serious knee injury. We've shown, and I'll show you some data in a moment, that even though all of these risk factors are on the rise, the increase in these factors doesn't come anywhere near explaining the threefold increase in knee replacement in the last 10 or 15 years. So we then wonder about expanding indications, and we can see this in our practices, that surgeons are much more comfortable operating on older and sicker patients as perioperative care has improved. And younger patients and patients who are less disabled are much more interested in having the surgery. And this is a phenomenon that we see all the time in the States, and I'm not sure how often you're seeing it here, is patients going on the internet knowing an awful lot about hip replacement or knee replacement and presenting at age 52 with functional limitation and asking for joint replacements, in many cases receiving them. We also we're graduating more and more surgeons who do these procedures, and it's possible that some of this is supply driven. And as I hinted a moment ago, the generation undergoing arthroplasty now increasingly is the baby boomer generation, a term that we use a lot to refer to people born between the late 40s and the mid 1960s, who have generally called the shots in terms of their health, and now that they're reaching the age of advanced osteoarthritis, are asking for joint replacement, and they tend to get it. Here's the increase in utilization of total knee replacement over the last decade shown again, and now we've broken down the older and the younger patients, with our older patients in dark and our younger patients less than 60 shown in light. And what you can see is that while the frequency of arthroplasty is increasing in both groups, it's increasing much faster in this younger group. And these are some data that I'll just show for a moment, showing the increases in the proportion of Americans in each age group, stratified by whether they're obese or not. And certainly we've had on the order of 15 to 20% increases in population across these age groups, and increases particularly in the obese population, but this doesn't come anywhere near explaining the 300% increase in arthroplasty rates. a couple of implications. One is what I've tended to think of as the commodification of total joint replacement. You know, a commodity is something that is defined as a good like a carton of milk or a box of cereal or a pound of peaches that tends to be widely available, very small margins, and where the key is to figure out how to handle goods in volume in order to make money. That's what's happening in the United States, certainly, to total joint replacement. So I distinguish it from Tiffany, a very fine provider of jewelry, to Target, one of our largest department stores that sells t-shirts for $9. We have diminishing margins per case. We have workforce challenges. It's unclear who's going to do these procedures. And so we're developing new models of care, and not necessarily by choice. Our payers are saying that we're not going to pay for all of these procedures at the same rate that we are now. And so the per case reimbursement is going down, and hospital surgeons are having to figure out how to provide the care more efficiently. Another issue I wanted to point out is the poor prognostic effect of having, is the prognostic effect of preoperative function and the effect of poor function on outcomes. These are data from a colleague of mine, Liz Lingard, from 4 different countries. It's a large study of knee replacement outcomes where we've divided the data according to the preoperative WOMAC function score, which is a functional status score, and then we look at WOMAC scores following surgery. And what you can see here is this is the group that starts with the lowest function, and this is the group that starts with the highest function. And the low functioning group certainly improves the most. The high functioning group improves the least, but the low functioning group has the worst score after 2 years, and the high functioning group the best score. So surgery, when it's done later in the course of functional decline, leads to worse functional outcomes. And we have then a real, I think, policy decision of whether we should be doing these surgeries in order to preserve function, in which case we would operate on those high-functioning people as they begin to lose, or whether to restore function, in which case we would be operating on low-functioning people. And I think it's a major policy question that most countries have not even begun to think about, no less address. The implications are that as we operate on people with better levels of function, who have not slipped, who have not become as disabled, we're generally operating on people who are younger, and as we mentioned a moment ago, they now have many years in front of them and have to think seriously about the risk of revision. And it's for those people that some of the new biomaterials and new approaches such as ceramic and metal on metal and resurfacing have been developed. And we'll talk about those in the last few slides. One or two more issues before I get there. The first has to do with volume of hospitals and volume of surgeons. This is an area that my colleagues and I have done a lot of work on, and I think at this point it's well recognized that high volume hospitals have better outcomes and low volume hospitals worse outcomes. And here's some data on mortality, dislocation, infection, and pulmonary embolus, showing the risk in the lowest volume hospitals, which is red, and the highest volume hospitals, which are yellow. And you can see that there's steep dose response relationships with higher risk in the low volume hospitals for these outcomes. For knee replacement, we see a similar pattern, higher, much greater risk in the low volume hospitals. We see this also when we turn to revision rates. So what we have here are low volume surgeons in the darker line and high volume surgeons in the higher line. And these are failure rates according to surgeon volume. And by the time one gets out about 2 years or so, we have failure rates on the order of 3% in our low volume surgeons and 2% in our high volume surgeons, and those are maintained as you get out further. And finally, if we look at pain and function, this is a more complicated slide, but we've divided our surgeons and hospitals so that we show here the high-volume surgeons in high-volume hospitals, and here's our low-volume surgeons in low-volume hospitals, and then the middle bar is where one is high and one is low. And if we look at WOMAC pain scores, WOMAC function scores, the people who are unable to fully extend and who are dissatisfied, these white bars, the low-volume surgeons, low-volume hospitals, the patients in that category have worse scores on pain, function, range of motion, and satisfaction than people operated on in high-volume centers. One observation I wanted to just point out is something that we published a while ago, and I think we and others have tried to follow up on this and haven't really been able to successfully, but I think it's a very interesting observation, and that is that patients who undergo hip replacement have better survival, not implant survival, but live longer than patients who do not undergo hip replacement, who have the same age, same sex, and the same level of comorbidity. And we worry that these data, which were obtained from, our Medicare population, which has thousands and thousands of observations, but limited clinical data to be able to do the proper adjustment. We worry that these data may be confounded, that we haven't adjusted properly. But we tried the best we could, and we can't make this difference go away. And I think this is another one of those sort of profound possibilities, if it is indeed possible that when people undergo a joint replacement and in so doing improve their level of activity and get out of their lazy boy chairs and start walking around, if that improves their overall health enough to make a survival difference, it would really affect profoundly the way that we think about joint replacement. So it would be nice to be able to address this question more definitively. And we'll close now with just some comments about some of the newer technologies that you've heard about, starting with hip resurfacing. So this is what a resurfacing implant looks like, is that you just put a little cap on the head of the femur rather than a large implant as we talked about earlier. It's the beginning of a very holy Jewish holiday today, and so I think it's worth pointing out that what many people describe this operation as putting a little yarmulke over the femoral head rather than a big implant, and it's just held in place with a little metal peg here. And so this procedure has the advantage that if you have to convert it to a full hip replacement, revise it to a hip replacement, there's much less bone that's been used in the first procedure. The problem with hip resurfacing is that the indications are still emerging. There's been a steep learning curve, and in particular, there are higher revision rates, especially in women, and especially in when a smaller head is used, which has to be done in smaller people. So the role for hip resurfacing is really narrowing at this point to younger, very active males who are willing to take a risk on a technology that's not as well studied as a conventional hip replacement, but which certainly offers an easier revision should they come to need a revision. Unicondylar knee replacement is another sort of less invasive procedure that is being used more and more. It's appropriate, obviously, only for unicompartmental osteoarthritis, so it's important to be sure that only one compartment is involved. It does save bone stock in younger patients. Like the resurfacing, it allows for an easier conversion to a revision knee replacement. But it does have higher revision rates. It has similar rates of pain relief, but higher revision rates than a conventional knee replacement. Metal on metal is an evolving controversy, I think some would say a disaster, in technology development for arthroplasty. These implants were used about 25 years ago, did not work out well, and were discarded. And the technology was revived in the last decade, because of this younger population who predictably would need a revision. And the thought was that metal on metal may provide a surface that would produce less wear debris, less osteolysis, and lower risk for revision. And so there were some experimental studies done. It was introduced in humans. And by the year 2010, 1/3 of all hip replacements done in the United States, and I think this is true around the world, were done with metal-on-metal implants. By late 2010, and certainly by 2011, we became aware that there were some terrible complications occurring with these implants, that the metal shavings, the metal wear debris, in some patients were highly immunogenic, causing what are sometimes described as pseudotumors, inflammatory masses that erode bone and cause rapid osteolysis. And a good many of these have had to be replaced. It's resulted in a lot of malpractice litigation, and for all intents and purposes, these bearing surfaces are not used anymore. Here's some of the data that helped break the story. These are data from the Australian registry, the Australian hip registry. This data is for total hip replacement, not resurfacing, but replacement. And here are the metal-on-metal implants, and here are the conventional implants using metal-on-poly. And what we're plotting are revision rates, and you can see that they are vastly different with threefold greater revision rates in the metal-on-metal group following a total hip replacement. Here are the same sort of data, also from the Australian registry, following a hip resurfacing. The resurfacing revision rates are higher in general than the total hip replacement revision rates. If we just look at those two graphs, if you keep your eye on the THR, non-metal on metal, and now at the hip resurfacing, the resurfacing rates are a little higher, but the metal on metal are higher still. Again, we see 2 to 3-fold higher rates of revision. Minimally invasive knee replacement is another somewhat fad-like innovation, in the sense that incisions are getting smaller and smaller all the time. The minimally invasive incision is defined as minimally invasive because it spares much of the quadriceps, and because of that it permits, at least theoretically, a faster rehabilitation. There's been no documented benefit in pain or function or revision. It is clear that patients leave the hospital a day earlier. It's unclear whether there's any benefit seen beyond about 2 or 3 weeks. For patients who care an awful lot about the length of the incision, this is probably something worth thinking about. Otherwise, I don't think it is, because the exposure is not as good. Computer navigation has been around for a while now, very costly. The idea is to help improve alignment of components. It does seem to do that, but there's no documented effect on implant survival. So I'm going to close with this final slide, just to sort of bring us back into the clinical realm and think about surgery and osteoarthritis, and especially joint replacement. One concept is that patients often have several problems at once. They may have a knee that really needs attention, but also a contralateral hip. They may have a problem in their other knee, and perhaps they have spinal stenosis. And there's a couple implications. One is that it's really important not to wait for your first surgery until all problems are really end stage and are preventing the patient from functioning, because then you have lots of operations to do in a short period of time, a prolonged period of disability, very difficult for the patient. It's also useful, I think, to, so to speak, lead with a winner. And this would, I think, among certain surgical subspecialties, cause a fair bit of controversy, but perhaps we're safe to discuss here that if you had to choose between whether to do a knee replacement or whether to do a shoulder scope first, I would do the knee replacement any day. people don't walk on their shoulders, they walk on their knees. It's a reliable operation. If you had to do a knee or a hip, you might even do the hip first because it's an even more reliable operation. It's really important that patients have a good initial experience, and it's also really important that the first surgery work because they're going to have to use that joint as they recover from others. When you fix one joint, you'll unmask others. Countless patients will emerge from a hip or a knee replacement with pseudoclaudication from their spinal stenosis. And it is not that they developed spinal stenosis because they had a knee replacement, but rather that now that they can finally walk 20 blocks rather than just 2, they've unmasked the spinal stenosis that they had all the time. It's important not to wait until patients are too sick to have surgery. There's a window of opportunity. A healthy 72-year-old with far advanced knee and a limp is probably a better candidate for surgery than the same patient might be 8 years later. Maybe not. But at that point, one is sort of tempting fate to keep waiting year after year after year because cardiovascular and pulmonary, renal, and other diseases do come into play. And finally, as I mentioned a moment ago, there is no need to use innovative implants in an older patient. And if your surgeons are talking about doing the latest thing, whether it be metal on metal or ceramic on ceramic, or whatever is new and down the pike and costs 3 times more than the traditional implant, in a 79-year-old with osteoarthritis, I would gently steer the patient toward a different surgeon. There's just no need to do that. The traditional Charnley hip is inexpensive, very reliable, and has a proven track record. The innovative implants are very important to think about in this younger population who know that they're going to have to face a revision. So I'll stop there and thank you one more time for your attention and for your wonderful hospitality here. And I've conveyed to you many things I've learned from my colleagues, not only in rheumatology, but also my colleagues in the orthopedic surgery department with whom I work very closely. And if we have time, I'd be very happy to take questions.
Bueno, vamos a abrir la sesión de preguntas para el doctor Katz. Doctor Juan Canoso.
Jeffrey, that was a wonderful talk.
Thank you.
I was wondering, in people, younger people with a total knee replacement who have a high revision rate, if you stratify these people who have a revision versus the others by weight, muscle strength, for example, in the quadriceps, type of exercise they do, could you perhaps identify a way that by modifying life factors, the revision rate could be decreased?
Yes, so predictors of high revision rates in these younger patients, there are some reasonable studies that have looked at this, and all of the things that you say are true. So people who are more obese are more likely to be revised than their non-obese counterparts who had a primary at the same time. And people who are more active are more likely to be revised. So it is one thing that's very important, I think, is that for many patients, losing weight with advanced osteoarthritis is very difficult, but they really do enable themselves to be much more active once they've had a joint replacement. And yet many studies have shown that activity level does not change after joint replacement. One of our surgeons says that patients watch TV painfully before their knee replacement and comfortably afterwards. And that is a lost opportunity, and one of the costs of it is that that weight does threaten the longevity of the implant. There's a lot of interest in this question of whether patients who've had, say, a knee or a hip replacement should be skiing, should be running, whether they should avoid high-impact activities. And many surgeons believe they should. There's relatively little data because it's a hard question to study. And many patients get the surgery precisely so that they can run and don't want to hear about it and sort of take their chances.
Thank you, Dr. Katz. I have a couple of questions. One would be, in resurfacing, you mentioned it's basically for young patients. Do they have to have a basically intact acetabular surface, or the insert works even in significant OA in the acetabular surface?
It works, yes, it works even if there's significant OA. It's different from, so you know, in the fracture situation, a hemiarthroplasty requires a relatively smooth acetabular surface, because that acetabular surface really is functioning as half of the joint. But in the resurfacing arthroplasty, a component is put into the acetabular side. I'll show you the picture again. Oh, you know, we don't see it that well. I'm sorry. I understand your question better now because, oh, here it is, yes. So here's what the resurfacing arthroplasty looks like. So there is an acetabular component, and then there's a femoral component. So, so essentially they get a new acetabulum.
Okay. The other question would be, you mentioned the significant lack of evidence of the benefit or damage caused by meniscectomy is a risk factor for progressive OA in patients, especially if they are older. There's also some studies that have shown, at least I've read some about this, that patients also suffering from anterior cruciate ligament ruptures do not do as well as we thought they would do. And basically, in patients that are older, maybe in younger patients, and they're very active, maybe it's worth repairing, especially if they're very active. But in older patients, it doesn't seem to make any difference in the outcomes, and it may even be the same OA development. Is this true?
Yeah, this is a very interesting and important question, and I'll take the meniscus and the ACL separately because they are sort of different. In the meniscus situation, we have some very nice data from many different investigators showing that having a meniscal tear is itself a strong risk factor for progression of osteoarthritis. We also know from some surgical studies that having meniscal surgery is a strong risk factor for osteoarthritis compared to, say, the contralateral knee or compared to population controls. What we don't know is if you already have a meniscal tear, is the risk of osteoarthritis progression increased by having surgery? And that we don't know. We're looking at that in our study because we're doing MRIs on all of these patients at baseline 18 months and 60 months. So we think that we'll have some feeling for that. But that's an important question, is whether there are biomechanical studies that show that an intact meniscus is very good at absorbing load. That's its role, really. That a meniscus that's repaired, that's torn experimentally and then repaired with stitches, is good at absorbing load. That a meniscus that's resected, where you actually take out the part that's torn, now becomes much less competent at absorbing load and transfers load to the bone. But interestingly, the meniscus that is torn but not resected or repaired also does not absorb load well. So having a meniscal tear translates into an incompetent meniscus, and having that tear fixed arthroscopically makes the patient's symptoms better usually, at least in the short term, but we don't know whether it increases load or not. The ACL story is interesting. It's you know, some of the early work that was done in experimental osteoarthritis was done by transecting the anterior cruciate ligament in dogs and sheep and other large mammals. So we know that ACL insufficiency is a risk factor for osteoarthritis. And as that has been looked at more and more carefully, it appears that the pathway may be mediated largely through meniscal tear. So patients with an ACL lesion who do not have a meniscal tear have much lower progression to OA than patients with an ACL lesion who develop a meniscal tear, either as part of the initial injury or subsequently.
I have a question. Do you have any data about if patients with rheumatoid arthritis have worse the outcomes in total knee or total hip replacements compared with patients with osteoarthritis?
So patients with rheumatoid arthritis have higher infection rates. They have similar or lower revision rates, and that may be in part because they don't wear the prostheses as much because they're more limited in their activities. It may also be because they have systemic disease elsewhere, so they're less likely to undergo a revision. They tend to improve a great deal following surgery, but because they have other joints and because they have systemic disease, a joint replacement does not cure their rheumatoid arthritis, obviously, and so they need to understand, but I think most rheumatoid patients do, that the knee replacement will help the knee, but it won't help their elbows and hands and all their other things. But the extent of pain relief in the joint that's operated on is similar for rheumatoids and non-rheumatoids.
In patients with rheumatoid arthritis, do you stop the pharmacy?
So that's a matter of some debate. How do you handle medication therapy in patients with rheumatoid arthritis undergoing total joint replacement or spine surgery, perhaps even? There's not a lot of very good data on this. I think that there's reasonable agreement that one should probably stop methotrexate a week or two before and not resume it until the patient is out of the hospital and their wounds are closed, for a couple of reasons. One is that methotrexate can accumulate in third spaces. So if the patient's in the hospital and developing a pleural effusion and that sort of thing, they can, if they develop renal insufficiency in the hospital, they can get toxic. So what we usually do is to stop methotrexate 2 weeks or so before surgery and not resume it until all stitches are out and the wound looks good. Biologic therapy, probably similar. There are fewer, there's less guidelines and there's less experience, but, and it depends on the drug, right, because there's different half-lives. So if somebody has had Remicade, I would try, and what I do try, is to not operate on them until they're at least 6 weeks out from their last injection. And I generally would not give them more Remicade until they're about 3 or 4 weeks out, all wounds are clean and that sort of thing. Enbrel, you can cut it a little bit closer because the half-life is smaller, shorter.
What do you think about the use of viscosupplementation in a previous stage for a surgery? I mean, instead of arthroscopy and lavage.
Viscosupplementation is another controversial area. Even the systematic reviews differ. There's a very recent review in the Annals of Internal Medicine that found some benefit to viscosupplementation. The prior reviews that were done by the Cochrane Initiative, which does very good systematic reviews, found no benefit to viscosupplementation. So I don't think we really know. We don't use it in our hospital. It's not on the formulary because it's felt not to work. And for that reason, I don't have any experience with it. I think that probably many of you do use it and perhaps might respond to this because I don't have any direct experience to bring to it. There certainly is a risk of acute inflammatory reactions that can cause emergency room visits for, kind of pseudo-septic knees that need to be drained and watched, and that's a serious complication. So, do you use a lot here, or does it vary a lot?
Yeah.
You use it? Yeah.
point of view, how many times you find underlying disease during the chirurgical treatment, especially in the knee surgery? How many times do you find underlying disease, like in Mexico, infectious disease, chondrocalcinosis, and this style of disease?
So when is there another condition like hemochromatosis or CPPD? Yes. And you know, I think it's always good to look. And then the question is, if you find it, was that really what caused the problem? Like, I think a common problem that I don't really know what to make of is a patient with advanced radiographic knee osteoarthritis and lots of chondrocalcinosis of the knee, who has an occasional inflammatory episode. And you know, does that patient have pseudogout leading to advanced osteoarthritis? Would they be better if you treated their pseudogout more aggressively? Usually I end up trying that, but replacing the knee ultimately. So I think we do see CPPD a lot, and I'm never quite sure whether it's an underlying disease or an associated disease. We don't see a lot of hemochromatosis, but I always kind of think about it. You know, especially if you see OA in the hands, less so in the hips. I guess we see so much age and obesity-related osteoarthritis that it's tempting to stop looking, and one probably shouldn't do that. One of the things that happens several times a year in my practice, and I'm sure you all have the same experience, is that a patient who has mechanical knee symptoms will see an orthopedic surgeon get scoped and be found to have flagrant synovitis and get referred to you. And then as you begin to work them up, you realize that they have an inflammatory arthropathy, sort of a writer's-like arthropathy. And I think that that happens reasonably frequently, that they present to an orthopedic surgeon and they sort of get the wrong procedure, but you do get a biopsy.
Let me invite Dr. Espinosa for my next question. Rolando, allá en tu hospital, ¿con qué frecuencia la cirugía de cadera unilateral llegan a encontrar cosas como tuberculosis o tumores? Que yo les he preguntado a los compañeros de ortopedia en Querétaro, y las más de las veces nunca mandan a analizar las piezas quirúrgicas, las más de las veces. Pero por ejemplo, cuando hay cirugía ortopédica unilateral, siempre te queda la duda de qué pasó. Y tú tienes un departamento de ortopedia bueno ahí en el hospital. ¿No hay datos de esto?
Well, Dr. Barreira talked about if you have a patient with just unilateral osteoarthritis, you very high level, you need to think sometime in tuberculosis or something like that. Yes. You know. Well, let me tell you something. Yes, we have maybe two different departments. One of these is for young people, and the other is for older people. Most of the people older is primary osteoarthritis. However, in younger people, or in patient, for example, 50 years old with unilateral osteoarthritis of the hip or knee, yes, most of the time they refer to us in order to study the cases. Yeah. Yes, sometimes we can find tuberculosis or genetic problems, collagen problems. Yes, we study this kind of patient. It's not very popular, not very common, but we have a special clinic for younger people who need total knee or total hip replacement.
Supongo que hay una diferencia también, porque aquí se ve más tuberculosis y nosotros vemos más y más ahora porque más y más gente viene de otros países con tuberculosis que está reactivado.
Sí.
So, es algo que estamos pensando más.
Hay una pregunta de internet. There's a question in the internet, Dr. Katz, from Dr. Jorge Alcaraz. He asks, what do you think about plasma-rich platelet administration in patients with OA and stem cell therapy?
Platelet-rich plasma and stem cells. I don't know very much about them. I have read a fair bit about platelet-rich plasma because I've been very interested in it, and I have a colleague who is thinking about doing a randomized controlled trial. It looks to me as though it doesn't work for tendinitis, bursitis, and I think that we probably could use some more studies, but there are a couple of rather good trials that suggest that it doesn't work in those soft tissue problems. Whether it would help healing in trauma, for example, I don't know. I think that's another popular use. And stem cells are really interesting, right? I think we just don't know yet what the role will be for stem cells. There's a lot of, I think, really fascinating work in bioengineering occurring now for cartilage defects, for example, to try to grow stem cells, place them in defects, use scaffolding to protect the stem cells so that they can grow cartilage. And some of that work is being done with autologous chondrocytes, for example. But I think we'll see a lot more of it, and I think we'll see more of it being done in fracture, and I think we'll see more of it being done in fusion procedures. So I think it's a very exciting time, actually, for stem cell research.
Excuse me, you talk about the replacement, the hip and knee, but what do you think about what's the matter with the trapezocarpianas in the hand?
So, nothing. So in the hand, I guess the most common procedures that we do is the carpal metacarpal arthroplasty, which is done with a tendon and without any implant. So it has many fewer long-term concerns. There's no osteolysis. And I think it's a very good operation. It has a good track record. So CMC osteoarthritis, I think, is a good operation. A variety of things have been attempted for osteoarthritis of the PIPs and DIPs, and none of them are really all that satisfactory to patients. I think we probably all do a lot of trigger finger releases for in the hand. So, but I think that CMCOA is a good operation. Wrist osteoarthritis, of course, is uncommon, and when you see it, it's almost always post-traumatic. And there's a very interesting choice, as in the ankle, between whether to do fusion, which is an extremely effective operation from a pain relief standpoint, but leaves you with a fused wrist or a fused ankle, or whether to do an arthroplasty, which is just not as well developed these days, and the functional results are not as good, the failure rates are higher, but which certainly allows more activities. And so those are evolving areas. I think Dr. Canosa had a question as well.
It wasn't a question. I was going to say that platelet-rich plasma makes money-rich doctors.
Yes. And companies, yes.
Dr. Cajigas.
What kind of anticoagulation do you use to prevent embolism? Is heparin, fraxiparin, or the new anticoagulants?
In our hospital, all of the above have been used because it still varies a little bit by doctor, but we're seeing a switch. So up until, well, still now, many patients are being given Coumadin, starting it the night before surgery and taking it for 6 weeks following a hip and sometimes a little bit less following a knee. Low molecular weight heparin is being used more and more. It's expensive, but there's no monitoring. It appears very safe and it's effective. So including monitoring costs, what the total costs are, you know, it may be sort of a wash, and it's a lot safer, I think. And then some of the newer agents, some of the thrombin antagonists, et cetera, they're still being used in trials. I'm seeing some patients coming in on those routinely now, but we're not really using them routinely yet. They're also very expensive, but I think we'll be seeing them. They're, you know, PO medicines, which is really nice because the heparin agents are injectable primarily.
Well, okay, if there is no more question, just say thank you very much, Dr. Katz.
Thank you. Oh, I'm going to wear it. Voy a ponerlo, gracias. Thank you very much.
Pasar al fondo, al fondo está el salón para el cóctel y quien quiera poder seguir platicando con el doctor Katz estará ahí. Gracias.